Welcome to Chapter 13. In Chapter 13, we talk about our healthcare delivery in the United States, which is a sore subject for many people, including myself. So hang on. There's a lot of stuff that's covered in this topic, in this chapter. And so without further ado, we'll go ahead and get started. The objectives of this chapter are to understand things like our healthcare system. What is the history of our healthcare system in the United States? Talk about the spectrum of healthcare delivery. We'll talk about the different kinds of healthcare, population-based care, medical practice, long-term practice, end-of-life practice. We'll talk about the various groups of healthcare providers. We'll talk about some different providers with under names you're probably not familiar with, like allopathic, osteopathic, and then non-allopathic. We'll define complementary and alternative medicine, why there is a need for healthcare providers, the different types of facilities in which healthcare is delivered, the different types of hospitals. We'll talk about what's the difference between inpatient and outpatient care. There's a lot more outpatient care than there used to be. The different options for long-term care. Do you get insurance? Do you not get insurance? Right? The concerns about the healthcare system in the United States. The various types of reimbursement. How do we pay people that give us health care? Types of health insurance and a lot of the terms that go along with our health insurance, like deductible and co-insurance and co-payment. And what does it mean to be self-insured as an organization? Right? I don't know that you're allowed to be self-insured. I guess you are allowed to be self-insured today. You used to not be able to. So the different government insurance programs like Medicare and Medicaid and CHIPS, which is Children's Health Insurance Program, and long-term. All right, managed care, the different terms associated with HMOs, the advantages and disadvantages of managed care, the Affordable Care Act, the most beloved, the most hated bill that was passed, at least in my lifetime. So, all right, well, let's get started. Healthcare delivery in the United States is unlike other developed countries. Other richer countries have a much more, I would say, organized and functional system than we do, although I know that my conservative friends would disagree with me on that, but I will try to make the case through this chapter that I am right. We'll see how I do here. It is delivered in an array of providers. We've got a lot of different people doing a lot of different things in a lot of different places. And so that's why a lot of people would say, you know what, we don't really have a system, because system is like our body. And so in our body, you have lungs, and they're responsible for pulling in oxygen and distributing it right to the heart. I guess the heart distributes it. But whereas our health care is not so systemic. You've got people all over the place doing all different things, and there's a lot of duplication, and there's also a lot of people falling through the cracks. And so that's why some people say we don't really have a system. We just have kind of random things doing various things. And if you have money in the United States, it's a great place to receive your health care, right? If you don't have money, then you are more likely to die earlier because of your lack of health insurance, your inability to access providers and pay for things like preventative care, which is really, really, really helpful. But it's easy to put that stuff off. And so anyway, go ahead and get started here with our history of health care delivery. So self-care just refers to what we do in our homes. So for instance, if I stub my toe and it starts bleeding, I am unlikely to go to an urgent care facility. I'm likely to say, I need to wash this out and put Neosporin in a Band-Aid. And so we've been doing that throughout history, and we still do it today. And in fact, as healthcare becomes more and more expensive, we're probably going to do more and more healthcare. And in fact, among the populations of the United States that don't have health insurance or have really crappy health insurance, they do a lot more self-care, maybe than they should. And anyway, going back to colonial times, it was pretty easy for people to practice medicine because there wasn't really a system in place that said these people can practice and these people can't, because we didn't have a licensing and laws that would have prevented hucksters from practicing. And so it's kind of expected, because if you think about where we were at, say in like the 1600s, we were fairly a new country in terms of, well, we weren't, I guess we were just part of the British Empire, but back in Europe, they had been doing organizing doctors for a long time, and so they had systems that provided better care than we did, and so it took us a while to kind of get organized. And medical education was mostly through apprenticeship. And so, typically doctors were men, and so a boy would apprentice under a doctor for several years and then become a doctor himself. So it was not grounded in science, because much of what we did was not grounded in science. And so medicine was mostly based upon experience. This is what we've done for a long time. This is, in my experience, what works. And so science, didn't play a huge role up until the late 1800s. One of the interesting things about receiving health care back in the 1800s was, and before that, is that most care was provided in the patient's homes. And the doctor would do home visits. And a few of them do today, but typically you have to go to the doctor's offices. There weren't very many hospitals. The ones that did exist were only in large cities and seaports. And they didn't have as many tools as they do today. They weren't necessarily clean places to go. And they kind of functioned more as a social welfare place. Places where people could go when they didn't have other places for other people to take care of them, say in the home. And almshouses were, again, places for people who weren't able to make it anywhere else. They didn't have jobs, or they didn't have people who would be able to care for them, and so they ended up kind of being in these hospitals, almshouses. A pest house is an interesting word. We wouldn't use that one today. It is a place where you contain people who have a disease. So if you have, an outbreak of cholera in Boston in the 1600s, you are going to put them in a pest house, hoping that they don't spread cholera to other people in the city. Late 1800s to early 1900s, it is more efficient to have patients come to the doctor than to have the doctor spend that time in transportation coming to the patients. And so care moves from our home to the doctor's offices and then the hospitals. If you'll remember from chapter 2, it's during this time when public health really kind of takes off and people are writing reports about city public health, and one of the recommendations that they're making is that we build more hospitals. And so this begins to happen. And so we have more hospitals, and the people who are working in them are better trained, and they have better supplies, and things begin to get better, especially since science begins to play a bigger role in the educating of doctors and other health professionals that are treating people. And mortality declines. And this is partly due to doctors, but I would say that it has more to do with public health measures such as clean water and clean food and more safety laws and things like immunization. And so, in fact, if you think about a place, say in a third world country where there's few doctors, and they're, not necessarily doing a whole lot to regulate the food that they're eating and in terms of cleanliness standards, and the mortality rate is high, as you would expect, it'd actually be better off in terms of mortality rates to work on cleaning the water and cleaning the food and washing hands. That would probably be more effective than, say, bringing in doctors. Obviously, doctors are great, but they are most they're most effective when it comes to acute things like someone has a broken leg or someone has an infection. That's where doctors really shine. And when it comes to prevention, that's more of a public health issue related to things like clean water and making sure people's diets are adequate. All right, the early 1900s, chronic diseases passed communicable diseases as the leading causes of death. We begin to eat better and we're drinking cleaner water, and we begin to understand how diseases are passed from one person to another. This idea of, that these microbes, which are smaller than the human eye can see. And so we begin to get good at reducing the amount of death from communicable diseases. And so as a result, chronic diseases begin killing us more than communicable diseases do, which is probably a good thing, right? We also have new procedures like x-rays and surgeries and various other things to treat diseases. Our trainings of doctors and nurses gets better, and in 1929 we're spending about 4% of all the dollars that are being exchanged hands in the United States. That's GDP, gross domestic product. But for me, I like to think of that as just the number of dollars that are exchanging hands every year. And if you add up all those dollars, that's gross domestic product. So we're spending about 4 out of every $100 on our health care. I think today it's around 12 or 13%. And we have a two-party system, kind of like our politics today. But those two parties are the patients and the physicians. And in some ways, that's fairly easy to understand. And that's important because it gets way more complicated here after World War II. So you have the patients, and the patients are going to the doctors, and the doctors are saying, hey, I'm providing the service, and I need you to pay me X number of dollars for that service, and the person is able to pay it or not able to pay it, I guess. But that is kind of simple, kind of like if you go to Walmart and you buy a cup. And Walmart says this cup is $4.99, and the person is like, oh, okay, I'll pay that, and it's just the two people, it's just you and Walmart, right? All right. And then World War II happens, and during this time, the United States government says you can't pay people more than X amount of dollars, and so depending on the job that you were working, your pay would be restricted, and there's not enough workers because many of the men are leaving to go fight in the war, and so they're recruiting people who are not soldiers, and many of them are women, and they're trying to get people to leave the homes or whatever else they were doing, if they were a farmer, let's say, or they were working another job, come work for me, but they can't attract them with money, so they attract them with health insurance policies, health insurance, to get them to come work for them, right? And so it's at this point where health insurance becomes something that is much more familiar to us and much more popular. We're also making a lot of technological strides during this time. It is actually during this time that penicillin is discovered or created. And this is an amazing thing because it really reduces the amount of deaths due to infection. And so with those technological strides, though, as you can imagine, the cost of money, cost of health insurance is going up and mortality is going down, right? So these are good things. But the Hill-Burton Act is passed, and what that does is it gives money to build additional hospitals. Right? We start getting better at treating people. We have better procedures and equipment, and all these are amazing, but they also mean a rise in the cost of health insurance. We begin thinking about health care as a basic right, but then other people are saying, no, it's actually not a basic right. It's actually a privilege. And so if you can afford it, then it should obviously be available to you, just like my cup is available to me if I can afford it. But people would say, just like cups aren't a right, they're a privilege, and so healthcare should be a privilege. And so, but it's during this time when we begin thinking about the idea of universal health care, just like we have, universal, roads, right? Everyone can walk on the roads. The rich can walk, not walk, but drive, or I guess walk too. We have universal sidewalks, I guess. But it's a universal. It's a right. I guess it's a right. The right to vote, I guess maybe would be a better one. But they're available for everybody. So obviously we did not choose a basic right. We chose that healthcare is a privilege. So in the late 1950s, we have a shortage of quality care and a maldistribution of healthcare services, right? So we don't have enough people to care for the population, and some places have a lot more resources than others, right? Probably probably pretty obvious to you as where they had more. They had more in the richer cities and less in the poorer countries, especially if they're a community of color. During the 1960s, there is increased interest in health insurance, which was again introduced during World War II. And this third party, which is the insurance company. Remember, before we had these two parties, we had the physician and we had the patient, but now we're introducing this third person who's paying for it. Sort of. Obviously, the patient is sort of paying for it. They're paying the insurance company or the government, which is then paying the doctor. And the cost of health care is rising for a lot of different reasons, but one of them here is mentioned is that if I am putting my money toward a health insurance policy and I decide, you know what, I'm going to go ahead and get more health care than I otherwise would, because if I had to pay for it myself out of pocket, I wouldn't do it. But because I'm sharing the expense with 1,000 other people, let's say, I'm not going to really see that much of an increase. And so people begin using a little bit more, healthcare, right? And then, of course, there are those who are just unable to afford healthcare. And why are they unable to afford it? Because we're raising the cost of healthcare. Also, think about if you have to go through an insurance company to receive your payment. Well, now you need people in the office who are focused on communicating with the health insurance company, which has all kinds of standards and things in terms of how things need to be billed in order for them to pay. All right, moving on. 1965, we introduced Medicare and Medicaid. We will talk about them more later on, but it is at this point when they are introduced. Moving on in history, in the 1970s, we as a country introduced the Health Maintenance and Organization Act, and it is looking for a way to bridge the gap between the service that's provided and the insurance company. We passed another bill called the National Health Planning and Resources Development Act. Again, we're trying to reduce this burgeoning cost of healthcare in the United States, trying to not build any unnecessary facilities that is believed to be part of the problem, is that we're overbuilding ourselves and we're having to pay to maintain those things. In the 1980s, President Reagan is elected and he runs on a deregulation ticket for the economy in general, and it obviously spills over here into healthcare. And it's a nice idea, this idea that you are going to have healthcare providers competing for people's business. And that's going to drive down the cost and drive up the quality of care. Right. The only issue with that idea, I mean, it works well like between like stereos, let's say, so if I can say like, oh, I really want a stereo that it does this and that, and it's like I can compare with Sony and Samsung and different stereos. But when it comes to healthcare, I don't usually have, first of all, the time. Like if I break my leg, am I going to be able to do research and think about, should I go to this hospital or go to this doctor? Should I go to the ER room, or should I go to the urgent care place? No, my leg is broke. I'm in lots of pain. I just need to go somewhere really quick so they can try to fix me, or at least make me feel better before they fix me. And we don't know the cost, so if I go to the place where you buy stereos, Stereo One, let's say, they're going to have a price tag right there. It's going to say $400 for this stereo. It's a $300 installation fee. But if I break my leg, the doctor doesn't tell me, oh, it'll cost this much for me to set your leg, and this much for pain pills, and this much for IVs, and this. I don't know. I don't know until I get a bill. I can ask, but typically, if I'm in a lot of pain and I'm in an emergency, I may not be able to even understand, and I don't even know if they'd be able to tell me. I'm not sure the laws around that. I want to say that they do have to tell us, but I just feel like it's a lot of responsibility, and I don't know if most people would be able to do that. So, all right, what else? A proliferation of new medical technology is entering into the medical field, and we begin to get more specific when it comes to health insurance programs. And this is where we begin selling people like cancer insurance or rehabilitation insurance, which I always kind of like sneer at because I don't really like those ideas of just like, well, I'm going to purchase health insurance for cancer, but if I have a stroke, well, then that doesn't really help me. It's like buying insurance for like a plane crash or something. But anyway, moving on. During the 1990s, American Health Security Act of '93, this was an idea that Bill Clinton had for universal health care, where everybody in the United States would have the same health insurance, but it was really complex. I think our book says it was 1,500 pages long, and ultimately it was defeated. Instead, what we did was we have this idea of managed care, right? And so if you think about the words, we're trying to manage the health care of the Americans. And so again, health care costs continue to grow. And here it says that the percentage of GDP expands, and the amount of dollars that we're spending, it always beats inflation. Maybe it didn't last year in 2021, but it typically beats inflation, which means it grows at like 8% per year. So it's typically, it grows faster than our wages do, and so on. And so managed care is trying to control this. It's trying to achieve efficiency. Maybe we can have one person do what used to be two people did, and maybe we can bring these other services under one roof so that people aren't having to leave and incur extra expenses, trying to control utilization. Like maybe doctors are running too many tests on people, and so we're going to just limit the amount of health care that is provided to people. If we determine prices ahead of time, then that'll prevent doctors from charging too much from their patients. And so things like that are kind of experimented with under managed care. In 2000, the World Health Report says that we are 37th in the world when it comes to our healthcare systems. And so they look at things like what is mortality rate, what is infant mortality rate, what is the odds that if you have this specific cancer that you're going to live, and all those sort of things are looked at in the health report. And we don't do as well as we like, and so there's a lot of talk about it. And then the Affordable Care Act is passed 10 years later under Barack Obama, and it is an attempt to, well, like the name says, make healthcare more affordable. It's actually a little bit longer name than just the Affordable Care Act, but it is trying to take some power away from health insurance companies, and really it's really actually a kind of a middle way point between what conservatives want, which is like a lot of competition and don't get the government out of healthcare. That's kind of just a general kind of a conservative principle. And then what kind of more progressive people want, which is the government to have total control. In fact, the government would be the health insurance provider for everybody, like Medicare or Medicaid for everybody. guess Medicare is what's usually talked about. And so the Affordable Care Act is kind of in the middle there. And so it provides these marketplaces where different insurance companies have to compete for our business. And it then puts rules on insurance companies saying you can't kick people off because they have pre-existing conditions and just various different things. But it is not well liked. We'll talk a little bit more about that in the future. Let's talk about the healthcare system from a structural perspective. Who is involved? Later on, we'll talk about the function, what they're doing, but for now, let's talk about who is there and where they're delivering that care. And so the who is involved is the types of healthcare providers, and the where would be the facilities where they are doing that, and then the types of care that are provided. All right, the spectrum, if you will, of healthcare delivery. We have population-based practice, and we have medical practices where people are providing that care, and we have specific long-term practices where people are usually living at this place for an extended amount of time, and then end-of-life practice, which is the end of people's lives. And while you might be asking, why is end-of-life practice in a separate category from long-term care? Because typically when you say long-term care, people are thinking of nursing homes, and isn't that where many people die anyway? And the reason why it's separated is that end-of-life care actually has a pretty unique philosophy that's kind of different from long-term care and then your traditional medical practices. It's more of a focus on meaning and focus on comfort during those last few months or days, I suppose, of somebody's life. So let's go into more detail here with this. So public health practice. These are aimed at an entire population, aimed at disease prevention, because it's a whole lot easier to prevent an illness than it is to treat it. And so we're focusing on preventing people from getting sick, like and convincing people to not start smoking or to quit smoking if they are smoking, specific protections maybe around sexually transmitted diseases. A lot of it is around education, with the idea that if people understand what causes problems, then they will be more likely to avoid them. And much of it is through the government agencies. There are other agencies that may do this, such as like a self-help group, but yeah, a lot of it is through government funding where people are trying to reach specific populations. We actually see quite a number of those agencies in our areas. All right, medical practice. It's divided into 3 different types of medical care: primary, secondary, and tertiary. Your primary care is oftentimes the family doctor. It's your primary provider where you would first go if you had something wrong with you, or just for preventative measures. I have a yearly checkup. Unfortunately, I don't, but that would be a good thing to do. Is to have that standing relationship with a primary doctor. And so if you have like a bump that shows up on your arm, you would go to that primary care doctor first. If they would say, you know what, I need to send you to a specialist, maybe a dermatologist, if it's a skin issue, then that would be an example of a secondary medical care. And if that person said, boy, I think that you have this issue and I need to send you to somebody who specializes in this type of treatment, then that would be an example of a tertiary medical care for an unusual, complex, or maybe the type of medicine that's practiced. If it's like a nuclear medicine, then that would be under a tertiary medical care. All right, moving on to long-term practice. An example of long-term practice would be restorative care. So you have surgery, say, on your knees, and you live in an apartment building where there's no elevator, and so you can't go home. You need to go to a rehabilitation center or a nursing home and receive care there until you are able to walk up those stairs. And then there's long-term care. Again, this may also happen in a nursing home, but it is, the thought is that the person is going to not be restored. They're there, they have a chronic illness or a disability, and so they won't really have the ability to sort of graduate out of the care facility. It's very time intensive, and it's going to include more basic tasks like feeding and washing and things like that. And then end of life practice, and this is typically like within 6 months or within 6 months of death. So if you go to the doctor and the doctor says you've got stage 4 cancer, I give you 3 months to live, then you might say, okay, it's time to call in hospice, which is an example of an end of life practice. And in order to qualify for this, you have to have a terminal diagnosis, and they might focus on comfort and keeping you out of pain and making sure that your last days on earth have meaning. And the difference between this and long-term care or medical care is that it is not going to be a focus on treating the underlying issue that is causing the terminal diagnosis. So you're not going to be treating the cancer. You may be treating the symptoms of the cancer, and if you you scrape your leg or whatever, they'll treat that, but it's not trying to get rid of that underlying issue. All right, let's talk about the types of healthcare providers. First of all, we've got quite a few of them in the United States. About 8% of us work as a healthcare provider. And you can see the statistics there. It's about 40% are in the hospital and 25% outpatient settings, and some in nursing homes and home health care. Over 200 types of careers in this industry, everything from nurses to public health professionals and so on. There are some independent providers, and so if you think about a doctor, because I think that's the one that people are probably most familiar with, they receive specialized education. It's like medical school is very long and grueling, and they get licensed, and they now have legal authority to treat some health problems and diseases. I know it says any health problems or diseases, but these independent providers could also include people like mental health, providers. Well, no, we're gonna skip that last thing I just said. There are two types of providers we're going to talk about here: allopathic and osteopathic, and then non-allopathic are more your alternative providers. All right, let's talk about allopathic providers. Allopathic providers provide specific remedies like pills for a specific illness, right? And we think of these people are MDs, they're doctors of medicine. And so I think of your allopathic are yours, like if you think about a doctor, like that's probably who you think of, an allopathic provider. They're the ones that are, maybe you go to your primary doctor, or it may be the ones that you go to when you have surgery, right? There are osteopathic providers, and these are different. You may not even realize that they're not an MD unless you look at their name tag or you look at the certificates on the wall. In many ways, they're very similar, except that the osteopathic is going to focus a little bit more on seeing the body as a whole structure and focus a little bit more on maybe manipulation of the body. So if somebody has a bruise, they may, maybe a bruise is a bad example, but they may do like what a chiropractor does, and they may do spinal manipulation, or they may do manipulation if somebody, say, has allergies, or and they may focus on pushing on the different parts of their face to try to create some relief from the symptoms there. So most DOs are like your primary doctor, whereas more MDs are working in hospitals. But that doesn't mean that most primary doctors are DOs. It's just that if you're a DO, you're more likely to be a primary doctor. So again, they have similar education and training. Over the last few decades, there's been an increase in non-allopathic providers here in the United States. And these are sometimes referred to as alternative medicine providers or complementary medicine providers. In the United States, it is my opinion that our doctors are really good at treating acute symptoms. So if you break your leg or you have some sort of issue that is like happening right now and it's causing lots of problems, they are good at treating that. You know, a surgery, setting a broken limb or something like that. But if you have an issue that is maybe it's harder to pinpoint the cause of the problem, like you have chronic fatigue, then this may be something where the doctors are like, maybe it's genetic or maybe it's just stress, and I'm not really able to help you as much with that. Allergies would be an example of that, where we're not really treating the underlying cause of the allergies. It's just we're sort of treating the symptoms. And so this is where a lot of people have gone to complementary medical providers who are saying, we can help with those things. We can treat your allergy problem. We can treat your chronic fatigue problem. Now, they're not very well regulated, so that's why some of them will claim to do all kinds of things, but maybe they can or maybe they can't actually help in that realm. But I've had some pretty good experiences with them. They're certainly cheaper than going to the doctors, and maybe that's one of the reasons why we have more people going to them. Your most common alternative medical provider is your chiropractors. Chiropractors are focusing on adjusting the spine. And while some chiropractors will just say, you know, we work on restoring what was there before, say, the accident, some chiropractors will say, we will treat everything, you know, basically. And we can use adjusting of the body to help with, you know, a myriad of different things. I'm trying not to get my opinion here in here too much. Acupuncturists are, you know, focused on the energy in the body and manipulating the energy, or what they might call the chi of the body, through, you know, pulling up that first layer of skin. You can't see what I'm doing, and putting a little like needle or some kind of pointy thing and using that to manipulate it. So, but then there are all kinds of alternative medicine supplements and things like that. If you go into even Walgreens, I mean, there's just rows and rows of things like what I have here. You know, this is nettle leaf and ash. Here's you can see. Saw palmetto and hawthorn berries and turmeric root, right? And is this working? Well, here's what it says. These statements have not been reviewed by the FDA, and this product is not intended to diagnose, treat, or cure anything, right? Well, why am I taking it? It's not meant to treat or cure anything, right? Well, I think a lot of people are saying, well, the FDA is not touching it, but that doesn't mean that it doesn't work, right? Another one, it's got lavender essential oils, right? So all those things would be examples of natural products that have not been evaluated by the FDA. But I sure wish they would evaluate some of those things. All right, there are limited or restricted care providers, and these are people who've received specific training in only one part of the body, like a dentist or an optometrist or a podiatrist, which is for foot, right? Audiologists, psychologists, and they will only deal with that one specific part of the body. But oftentimes their training extends beyond just that one part, because, you know, if your dentist gives you medicine, let's say, it may have an interaction with your heart, so they need to understand the entire body. All right, nurses. We have quite a number of nurses in the United States, and the demand doesn't seem to be reducing in any way, because we've got a lot of people who need nurses. So we have a long-standing nursing tradition in the United States, and here our book identifies 3 different types of nurses depending on the training and the education that they have. LPNs are those with 1 or 2 years of education and then have to pass an exam. Registered nurses, or RNs, generally have 2 to 4 years of education and then an exam. And then advanced practice registered nurses are those with a master's or a doctoral degree. All right. So there is a large demand for doctors in the United States, and it is a long time. It takes us a long time to produce a doctor, and it's very expensive for the individual to become a doctor, and it's very, very difficult to get through medical school. And it seems like it's not even really a healthy process that we put doctors through. We keep them up for very long hours while they're on residencies in training to become doctors. So all that is to say, we don't have that many doctors in the United States. We need a lot more. And so the one solution to that is physician assistants. What they do is very similar to what a doctor does, but they don't have the medical degree. Right? They're sort of a mid-level between a doctor and a registered nurse. And in many ways, they are similar to, shoot. Okay, they're not, what I was going to say is that they are similar to nurse practitioners, but that's the next slide or down the road here. All right, there are allied healthcare professionals. And so while we've identified nurses and doctors and dentists and other people like that, there's a whole slew of people that are assisting the doctors and the nurses provide the care. And that's going to include people like laboratory technicians and behavioral scientists and people who are doing the paperwork for that and the assistants to the dentists. And so obviously, you've got a lot of different things going on here, and the education and the training for those things depends on what they are doing. All right, there are public health professionals, and so these are many of the same positions that I just mentioned, like a doctor or a nurse or a dentist, but they are working for a clinic or an organization that is a public health organization, and so that is financed by tax dollars, and it's for the public. In some ways, maybe it's like a someone who works at the driver's license bureau. They are financed through tax dollars, and it's available. It's available to everyone, I suppose, but it's primarily serving those who are economically disadvantaged. So if you find, if you go to one of these places, it's oftentimes people who don't have a doctor outside of this public health organization. Moving on, let's talk about healthcare facilities and their accreditation. So the physical setting is where the healthcare is provided. And so we're dividing up these facilities into two different categories depending on whether the patient sleeps there or not. If the patient sleeps there, if that's an option for you, if you have surgery and then you stay the night, then you are in an inpatient care facility. But if you don't have that option, then that is an outpatient care facility. This applies to hospitals. This applies to even mental health facilities. So if somebody goes to a mental health facility, it's oftentimes divided based upon whether they sleep there or not. Inpatients, they are sleeping there, or they can, and then outpatient, they don't. There's been a large rise in the number of people who used to go to inpatient care facilities for a procedure and are now going to outpatient care procedures. And some of that's due to technology and some of that's due to cost. So what are some examples of inpatient care facilities? Hospitals, nursing homes, assisted living facilities. Looking specifically at hospitals, they are categorized by who owns them. The one in Marion is a private hospital. It is there to make a profit. There are public hospitals, and those are the ones that the government has jurisdiction over. It's a government hospital. And then there are voluntary non-for-profit hospitals, and that's the ones like in Carbondale and SIH, I believe all of their hospitals, the ones at Heron and Carbondale, those are all non-for-profit hospitals. There are teaching hospitals, and then there are limited service hospitals where you can just have certain things done. I think of the Shriners Hospital. They're only working on a specific population for a specific issue. All right, outpatient care facilities, again, these are the ones where they're going to close at 9 o'clock at night or 5 o'clock at night. There's nobody sleeping there for that. So these are going to include the doctor's offices and clinics and retail clinics, which are popping up in places like Walgreens, and urgent care centers and surgery centers. It uses the word ambulatory there. That word threw me off. What it means is that the patient voluntarily leaves their home and goes to a place, and the idea is that they're going to then leave at the end of the day. So there are group practices, which is just a more than one practitioner in a place, as opposed to just one doctor's office where he's the only doctor there. All right, let's talk about a clinic. You have 2 or more physicians that are practicing as a group. They do not have inpatient beds in clinics. Why would a physician want to do this? Well, whether you're alone or whether you're with another doctor, you're still going to have to pay for the rent of the facility. You're going to have to pay for have the water, flowing there. And oftentimes it's just cheaper if you have 2 or more doctors operating in a single building than it is for an individual doctor to be there. And sometimes if they specialize in different things, then kind of one hand kind of shakes the other. It's like, oh, well, I can't treat that, but my partner across the hall, he does treat that, rather than sending them somewhere else. So there can be for-profit or non-for-profit. By the way, let's just make sure we understand what non-for-profit is. It doesn't mean that people who are there are not being paid. It means the owners are not being paid. So for instance, Shawnee College is non-for-profit because Shawnee College is owned and controlled by the community. So the community doesn't receive money from Shawnee College. In fact, it's the other way around. Whereas some clinics are for profit, and so that means that they could be started by an investor. So that means somebody who's not a doctor, like maybe you or me, we could say, boy, I think that this town needs another doctor's office, and I'm going to put some money toward that to start it, and we're going to hire a doctor, and that doctor is going to run it. And if we have more income than we have expenses, then we're going to split those profits between us. Other types of outpatient facilities, again, there's retail clinics that are in pharmacies, and these the advantage of these are that the cost is being controlled, and they're a little bit more convenient than going to a doctor's office. And if you get a prescription, then obviously you're right there in the pharmacy. Urgent care centers are kind of a middle halfway between a clinic and an ER room. And so, if you need to go to the doctor and it's, 4 o'clock on a Sunday afternoon, you can't go to your doctor's office because they're not there. And the ER is the most expensive place that you could go, and maybe you don't need an emergency room. Maybe you just need an urgent care center. So. Ambulatory surgery centers, again, these are places where people are voluntarily going to have surgery. And many of the surgeries that used to happen in inpatient facilities, like a hospital, are now happening in outpatient facilities. And maybe that's good and maybe that's not. It seems like some of the time the person should be spending the night with a doctor monitoring their health, but we've also gotten much better technologically at doing surgery, and so more people qualify to be able to leave. So. A non-hospital based specialty facility, this would be a place like a kidney care center, or a place where they only do certain procedures like a scanning. There's a place in Cape Girardeau where I go, and they do scans, and for a much cheaper price than if I were to go to a hospital. All right, long-term care options. Many people's actually greatest fear of getting old is that they would go to a nursing home. But I always want to point out that nursing homes are actually medical facilities, not just places where old people go. You don't just go there if you turn 80 or 100, and you have to have a medical reason to go to a nursing home. So other things would be things like group homes, transitional care from one place to another, daycare, home health care. Most people would actually prefer to remain living at home really until the day they die, especially if the other options are a hospital or a nursing home. And so it's actually a bit cheaper, or it can be cheaper, to have somebody come into the home, especially if it's only for, let's say, a few hours a day. Then that's going to be cheaper than having to have them in a long-term care inpatient facility like a nursing home. So there is increasing demands for long-term home health care. In 2016, Medicare paid $18 billion in home health care costs. So, yeah. Accreditation, right? We want to know that when we go to a healthcare facility that there's some sort of organization looking over the shoulders of this organization that we are going to. We want to know that there's somebody looking over the shoulders of a doctor's office or a nursing home saying they are doing at least some things right. We are checking in on them. We've looked over their books. We believe that they are maintaining at least a minimal quality of care at this place. All right, let's talk about the structure of our healthcare system from three different, the three things that are expensive, or the three things that are issues, major issues. And so those issues are cost containment, quality, and access. We can't have healthcare cost too much. People won't be able to do other things with their life if the cost is not contained. That's very important to us, right? But we also want our healthcare to be of a good quality. Otherwise, it's not functional. Like if you don't believe that going to the doctor is going to make you better, then you won't go. It ceases to serve the function for which it was even designed for, right? And then there's access. You have to be able to go to the doctor. You have to be able to afford to go to the doctor. Otherwise, it's inaccessible to you. So for instance, you could have amazing quality, and it is pretty cheap, but if nobody can get to it, then it's not really functional, right? You could have amazing access where everybody gets to go there, but it is extremely expensive, right? And the quality is low because you are unable to provide enough doctors and nurses to treat those people. So all of them are really important, and they're kind of like intermeshed into a relationship, right? And typically, if you have more of one, like you have more access, then you're going to compromise the other two. If you expand access so that everybody gets it, now you're going to really expand the cost of this, right? This is the argument against Medicare for all, right? Universal care, is that the argument is that we're going to lose our ability to pay for it. We're going to have to, really pay more in taxes, and the quality is going to be lower because we don't have enough people to treat all the people that, if you made healthcare accessible to everybody tomorrow, people who haven't been to the doctor in 10 years suddenly feel like, oh, I can now afford to go, and so I will, and so you're going to have doctors overwhelmed, and the quality is going to go down. So this is like all three of these are important. So. All right, talking more about access to healthcare here, right? Insurance coverage. Do I have insurance? And do I have good healthcare insurance? Because if I do, then I will have access to healthcare. And if I don't have health insurance, or the insurance that I have is bad, meaning I'm going to pay for most of my care, then I'm not going to access my health. I'm not going to access healthcare, right? And so for this, we look at who has health insurance in the United States. And this is only one thing, because a lot of people have health insurance, but they don't really have good health insurance because it's so expensive for them to go to the doctor because their insurance company doesn't pay for very much of it. But for now, we'll just look at the uninsured population. So after the Affordable Care Act was passed, more people became insured. And so what you can see here is that in 2015, you have about 9.1% of the population that is uninsured, right? And then in 2017, you have 7.9. So you have, millions more people who are insured under the Affordable Care Act. But then we take away the individual mandate and we begin, being really critical of this, and more people become uninsured in 2018. Okay, so who is uninsured? Well, it is a greater likelihood for minority adults. Why adults? Well, because we have programs that are specifically for children, and those are a little bit easier to access than it is for adults. All right. Talking about access more. Lack of access to primary care, and that's that first level, right? And why aren't people going to even that first level? Well, oftentimes they lack health insurance, or if they do have a level of health insurance, again, they feel like it is too expensive for them to even go to that primary care. And so, if someone's broken their leg, they're unlikely to not go to get treatment. But it may be that they're saying, you know what, I feel okay. I know I haven't been to the doctor in a few years, but I can't really afford it, and nothing's really wrong with me anyway, and so I'll kind of just skip that. So that would be an example of, how lack of health insurance or good health insurance is going to limit people's use of primary care, right? Let's talk a little bit about the Affordable Care Act. One of its main goals was to increase the number of Americans with health insurance. It did that to some degree. We've been erasing those gains slowly, but what it tried to do was to create an insurance marketplace so that different companies are competing for our health insurance needs, and the government's coming in and providing some money to help us pay for that. Now, it seems as though in the past few years that hasn't really worked out very well, so that if you use the health insurance marketplace, one, it's difficult to use because it takes you like a half hour to actually get to the place where you can see the offers, and then a lot of times there's only one company that's even offering, so it's not really a competitive marketplace like it was intended to be. All right, let's talk about quality of health care, right? Ideally, health care would be effective, right? It would be safe, and we wouldn't have to wait in line for a long time, and it would be about us and not just about paperwork, and it would be equitable, which means that, whether I have money or I don't have money, or I'm a man or a woman, it would be the same, right? And it would be efficient. We're not doing a bunch of things that don't need to be done just to, say, make more money, or just this is kind of just what we do. The cost of and paying for health insurance, right? Okay, so in 2018, our health expenditures were $3.6 trillion. A trillion is 1,000 million. No, it's not. A trillion is 1,000 billion, right? I kind of get lost after we talk about 100. After 100 million, I kind of get lost here. This number helps me a little bit more. It's $11,000 per person per year. So everybody in America is paying, on average, $11,000 per year, right? So it's 300 and some odd million people in America. Every one of them, on average, paid $11,000 in 2018. So we are the biggest spender on healthcare in the world by total spent. In fact, if you compare the rest of the countries below us, we really outspend them pretty significantly. It's not really that close. Where does all this money come from? It is out-of-pocket payments. It's third-party, like private insurance, or government health insurance programs like Medicare and Medicaid. It is employers. The cost of and paying for healthcare. Okay, so when it comes to understanding insurance, there's a lot of new terminology that we don't really use outside of the insurance industry, or at least I never use this terminology. And so let's talk about some of these terms, because if you don't have health insurance now, you may at some point, and it's helpful to understand these things. Reimbursement is just the generic term for when somebody provides a service, they will get paid by either the person or the insurance company afterward. Kind of a simple idea there. And it's fee for service, which means if you provide the service of, say, taking an x-ray, then you get paid for taking an x-ray, and it's kind of that's all you get paid for. It's just that sort of thing. Packaged pricing. And so packaged pricing is where maybe you go to the eye doctor and they say, well, we will do an eye exam and we will provide you with prescription glasses, and we're going to kind of wrap all of that up into one price. Right? Resource-based relative scale value. Okay, so as healthcare costs have ballooned, the government has said we are going to put a value on the certain procedure, and so it may fluctuate. And this resource relative value scale, it's created by Medicare, and it just says these procedures should take this amount of time and require this number of people, so therefore this is what we believe, this is what we're going to pay for, this is what we believe it's worth. Right? All right. Capitation. This is a monthly fee that is paid to a provider that has an agreement with, say, an insurance company, and they get that amount whether or not they provide a service to the people that are on that health insurance policy, right? So let's say me and 10 of my friends are in a company and we say we want health insurance, and so we call up Blue Cross Blue Shield and we say we want health insurance, and they say, okay, we're going to put you on a capitation plan. I'm making all of this up, by the way. And so we are going to contract with a doctor in your town, and that doctor is going to receive a fee from Blue Cross Blue Shield every month. And then when you, members of the company, when you need to go to the doctor, you go see them. And so if you go to them a lot, the doctor may not make very much money. And if you don't go to them hardly at all, then they're going to make a lot more money, right? But it's about that monthly fee that's paid to that doctor through the insurance provider. So prospective reimbursement. This is the amount of money for a service they agree upon the amount in advance. Prospective reimbursement. So if you go to the doctor and the doctor says, oh, you need this procedure, then the doctor may call the health insurance provider and they may say, okay, the health insurance says we want to pay $1,000 for this procedure, and the doctor says, okay, so I'll take $1,000 for that procedure, and so that would be a prospective reimbursement. It's before the actual thing is done, right? And then there's pay for performance, and this is rewarding organizations, health organizations, for meeting certain benchmarks, for certain quality measures. So if the health organization produces, this number of positive, let's say surgeries, they have this many successful surgeries, and we measure those by people not having infections and people leaving the hospital early, then we're going to pay extra for that. All right, Who pays for our health care? So as you can see here, the vast majority is paid by the health insurance companies. Of that, private health insurance pays for 34%, of that 75%. Medicare pays for some. You have children's health insurance, you have Medicaid rather, sorry, paying for some. Then you have 10% of the total cost is paid out of pocket. I really feel sorry for people that are paying health insurance, for paying for medical care out of pocket, because here's what I notice when I look at my health bills, and they are complicated, is that the health insurance company, even if they don't pay the bill, it's almost like they say to the doctor that I've gone to, he's with us, therefore you have to knock down your bill. Sometimes it's significantly, that's like 50% sometimes. And then they say, oh, okay, if Jesse is with you, then we'll only charge him half of what we would have charged him if he didn't have any insurance, which to me almost feels like it's like a mafia type of thing. Like, he's with us, therefore you only charge him this amount of money, even if the insurance company isn't really paying any of themselves. So I guess it's good for those who have insurance, but it seems like it's really bad for people who are paying out of pocket. So, all right, moving on. Health insurance. What is health insurance? And why would you want to do it? So if you think about it like this, you are probably not going to, say, have a heart attack this year. Odds are that you are not. But if you do, it's going to cost you $50,000. And so you'd say, I can't afford $50,000. And so what you would do is go to other people and say, hey, I bet you also can't afford $50,000. So let's kind of all pool our money before we need it together. And so that if one day one of us needs it, it'll be there. Right? And so the health insurance company kind of functions as that. They take the money every month, and then if we need health care, then they're there to protect us against risk. It's the same thing for fire insurance. You're unlikely to have a fire, this year. So why do you buy fire insurance? Well, if you did have a fire, it would be catastrophic for the cost of it. And so you kind of bet against yourself in a way. You're betting that you are going to have a fire, and the insurance company is betting that you won't have a fire. And so it's a calculated risk for them. All right, let's talk about some terms that are related to a health insurance policy. And for this, I'm going to use a make-believe $2,000 bill here, a hospital bill. So a premium is the amount that you pay or the client pays to the health insurance company every month. Whether you use whether you go to the doctor, use any health care, it doesn't matter. In order to be a member, you got to pay a premium. Okay. The deductible is the amount of money that you have to pay first off the top before the health insurance company pays anything. Okay. So, and oftentimes it's per year. Like there's a deductible every year. Okay. So for this example, let's say the deductible is $1,000. And so I haven't used any health insurance this year. And so when it comes to this $2,000 hospital bill, I would pay the first $1,000, and that's my deductible. Okay, so there's $1,000 left. The health insurance company then says, okay, you've paid your deductible. Now we will begin to pay, but there's still a part you have to pay, a percentage, and that is called your co-insurance. And so oftentimes it's 80%. And so the health insurance company says, we'll pay 80% of the remaining $1,000. Because remember, I paid the first $1,000 as part of the deductible. You are going to then pay $200. That's your 20% of the remaining $1,000. Okay. A co-payment is a fixed amount of money that, say, for things that usually it's things that the the health insurance company wants you to do, like go to the primary doctor to get your shots, let's say, and so it may be like $20 for an office visit, and so that would be an example of a co-payment. It's fixed, right? All right. Speaking of fixed indemnity is the maximum amount of money that they will pay for a procedure. So let's go back to my $2,000 bill. Let's say that the health insurance company says, you know what, this procedure that you had done, we have a fixed indemnity around it of $1,500. That means that the place where you went charged you above and beyond what is customary and normal. And so it would look like this. I'm paying the first $1,000 because that's my deductible. The insurance company says, okay, we are going to get rid of this. We are going to say this is actually only worth $1,500 in our minds, and so we will now pay, since you've already paid $1,000 on this, we will pay the remaining, well, a portion of the remaining $500. I still have to pay 20% of that $500, which is $100, plus the difference between the original amount, which was $2,000 and $1,500. So I end up paying $1,000 for the deductible, $200 for the co-insurance, and if there's a fixed indemnity of $1,500, I'll have to pay another $500 related to that. So, all right, you can tell I'm bitter here. Exclusions. An exclusion is where the health insurance company says we don't do these things. We don't pay for this type of health insurance or this type of health care. So for instance, if you have dental insurance, you are probably going to not be able to get your insurance company to pay for braces because they would say that's part of our exclusion. That is cosmetic, right? All right. And then there's pre-existing conditions. This is something that I feel like is more in the past. Insurance companies would say if you say have a chronic illness that is very expensive, then they may not pay for that condition, the treatment of that condition, or they may exclude you completely from their policy because of a pre-existing condition. And so there were a couple of laws that were created to help people with this. One was the HIPAA Act, and then the other was the Affordable Care Act, which the Affordable Care Act, I think, made it so that insurance companies cannot exclude people based upon pre-existing conditions. Of course, the fact that they can't exclude people means that the cost of health insurance is going to go up because now they have to. Anyway, let's talk about the types of healthcare insurance. I mentioned dental, which includes dental procedures. There's hospitalizations, long-term care, optical, and various other ones that I'm not going to go on much longer here. Let's talk about the cost of health insurance. The cost of insurance mirrors the cost of care. So if the cost of care goes up, the cost of health insurance going up, because most insurance companies are run for profit. They're not run to lose money or even to break even. And so every time the cost of care goes up, the cost of your insurance is also going to go up. This primarily falls on the employer. 57% of adults receive their health insurance through their employer, and so the employer then has to figure out how to pay for that. And unless you're a highly profitable company and you're able to eat those costs, most of the time they are passing those costs on to the employee, or in terms of raising the deductibles. So if maybe you have a $1,000 deductible last year, but the cost has gone up, then maybe your deductibles are going to go up to $2,000 or $3,000. And so trying to figure out how to pay for those sorts of things. The cost of the policy is determined by the risk of the group and the amount of coverage provided. I don't mean to get ageist here, but if you have a group of people working for an employer and they are elderly, then the expectation is that they are going to be using more healthcare and more costly healthcare. And so oftentimes that the group of employees as a whole will be paying more for that. As opposed to if you, say, work for a tech company and it's mostly 20-year-olds who rarely go to the doctor, then the cost of the policy is likely to be much lower. All right, there are some companies that are very large, like Berkshire Hathaway, which is, what's that guy's name? Warren Buffett's company. And they will be self-funded. So rather than giving the money and the premiums to an insurance company like Blue Cross Blue Shield, they will say, we're going to be our own health insurance company for our employees rather. And this benefits the company because they get to set the prices and decide what care they're going to pay for and what care they're not going to pay for. All right. The government also is in the health insurance industry, right? Oftentimes, it only provides health insurance for a select group of people. You know, we are not a country that provides government health insurance for everybody. Medicare is for a certain group of people, as is Medicaid, and then children's health insurance obviously is for children. We're going to go into more detail here in this slide. Medicare is for people who are 65 and older, who have permanent kidney failure and certain disabilities. It is a federal health insurance program. It's not run by the states individually. Social Security Administration handles people's enrollment in that. Again, it's for people who are 65 and older, and this is actually one of the things that keeps people working. Because health insurance is so expensive, people oftentimes wait until they're 65 or older to retire, because then they know that they can qualify for Medicare for their health insurance. It is paid for by an employer tax. There's 4 parts of it: Part A, B, C, and D, covering various things like hospital insurance, which everybody gets. Part A, actually, my next slide goes into more detail on this. All right, Part A is mandatory. Everybody gets it. There's a deductible and a coinsurance, which means people may have to pay in addition. They may have to pay the first part of it, and they may have to pay for procedures. Again, it's related to the hospital. Part B is people are automatically enrolled in it unless they choose to decline that. Part C is kind of a combination of private insurance with government insurance, and it tries to fill in the gaps. So, you know, we mentioned that there's a deductible here in Part B and a coinsurance, as well as they're here in Part A. Well, Part C is optional, and it's through private insurance companies, and it's paying for some of the things that are missed in Part A and B. Right? Part D is also optional, and it is run by insurance companies. Is Part C not optional? All right, I don't know if it's optional, but it is part of the attempt to control cost of medical care by including private health insurance companies with that. Part D is optional. Part D relates to prescription drugs, which, by the way, I have read that soon the cost of drugs will actually be more expensive than than going to see your doctor, getting procedures done. So that's kind of hard to believe, but I hope that day never comes. Let's talk about DRGs. This is the amount that is paid based upon the diagnosis and the sex of the person and their age. And it is done to encourage hospitals to discharge patients more quickly. Right? It's like a formula. Like if somebody enters into a hospital and they have a certain diagnosis, then the DRG comes in and into play because it's saying, okay, we're going to pay this amount for the care of that. And if you choose to run extra tests and do procedures and keep that person in the hospital longer, then that is going to cause more expense for you, and we're not paying for that. Whereas if you discharge them earlier, then you will get to keep that extra cost that maybe otherwise you would have paid for. All right, Medicaid. Medicaid is a health insurance program that is for low-income individuals. There is no age requirement for it. Anyone who makes within 133% of the poverty line, which means you can not be poor but be pretty close to being poor and still qualify for Medicaid. There's about 76 million people in the United States who are covered by Medicaid, and it's solely based upon income, not like home ownership or a race or other things like that. So a family of 4 today can make about $34,000 and still qualify for Medicaid. All right, CHIP. This is, oh gosh, what is CHIP? It's for children. Children's Health Insurance Program, created in '97, and it's been kind of funded and for a few years, and then it's renewed, and it is targeting children who are ineligible for Medicaid because their parents make too much money, but maybe their parents don't make enough to be able to pay for private insurance. And so I think you can make up to 4 times the poverty line. So for a family of 4, I think it's around $90,000 before the child is unable to qualify for CHIP. And it's a combination of a state and federal program. I think the federal government pays for most of it, but the state kind of manages it. All right, let's talk about problems with Medicare and Medicaid. These are programs that were created to help provide health care to groups for whom obtaining private health insurance would be difficult or impossible. Right, so that is the purpose, is that everybody would have health insurance because health insurance encourages people to use medical care, and that's especially important when it comes to preventative care. The problems are that not all providers will accept Medicare or Medicaid because they're not always very good at paying, first of all, the full price of the care, and oftentimes it's late. It takes a long time to get paid. So some providers are just saying, I don't accept Medicare or Medicaid, or I only accept 10 patients per, at a time. And so once they get 10 patients, they're saying we don't take any more. So and then also fraud, where the providers are saying that they are doing the procedures and they're not. All right, supplemental health insurance. This helps cover out-of-pocket costs that are not covered through primary insurance. And these are things like Medigap, which I mentioned earlier. Long-term care insurance. So long-term care is oftentimes not covered by Medicare or our private insurance. Most people, I don't think, really realize that. But if you need to go to a nursing home and all you have is basic Medicare or basic private health insurance, it's unlikely that your health insurance provider is going to pay for that long-term care. And so some people will purchase long-term care insurance, and this is great if you can afford it, but it is extremely expensive. But the purpose of it is to preserve financial assets. Okay, so it goes something like this. If you say a woman is 85 years old and she has $1 million worth of assets that she owns, her home, her car, retirement assets, or whatever. And she needs to go to a long-term care facility for care. That is going to cost her about $90,000 a year, okay, if she pays out of pocket. Again, Medicare is unlikely to pay for very much because they're saying we are going to pay for medical care, and if you go to a nursing home, let's say, or a long-term care facility, that is going to be a lot about food and shelter and bathing, and that is not what we are going to cover, or at least not for very long. Maybe you can get like a few days or maybe even a month, but if you're going to be living there for years, and so if she has $1 million worth of assets, then if she is there for 10 years, then all of those assets will be gone, right? Pretty much, because it's $90,000 a year. And so assisted living is half that cost, but if she has long-term care insurance, then that will pay for her care, and so that when she passes, then her heirs would receive her $1 million in assets. If she's like most people who don't have $1 million in assets, maybe they have $200,000 in assets, then what will oftentimes happen is that the person will have to spend all of their assets, go broke, and then they will qualify for Medicaid, which is the health insurance for poor people, and then they will pay for her long-term care, but then her heirs will not receive anything because she had to spend it all before she qualified for Medicaid. So it's really an unfortunate thing because people who are poor, they want to pass on a little bit to their heirs so that they don't have to struggle as much, but they then have very little options in terms of having somebody care for them. So most of the time, this long-term care is actually provided by the family members rather than the professionals. All right, managed care. The goal of managed care is to try to control the cost of health care. Right? This was something that we started a few decades ago as healthcare costs begin to really grow, trying to say, okay, how do we reduce the cost of this? And this is managed by managed care organizations, this MCOs, and they have an agreement with a provider to provide services that they would normally provide, but they're going to provide them at a reduced cost to certain individuals who are a part of these MCOs, right? And how are they going to do that? They're going to limit people's choices. So if you are a part of this managed care organization, they're going to say you can only go to these people because they've agreed to receive a discount. And why would a doctor agree to receive a discount? Well, they feel like they're going to receive a lot more clients from this MCO if they go ahead and receive and agree to this sort of thing. Gatekeeping, which would say if you can't go directly to the specialist, you have to go through your primary doctor, and they have to okay you to go on to the specialist. All right, types of managed care. There are PPOs, which is Preferred Provider Organization. This is where all the health insurance I've ever received is a PPO, and this is, we have certain people that are kind of in the club, and if you go to these people who are in the club, it's going to be a lot cheaper for you, your deductible will be less, whereas if you go outside of network, it's going to be a lot more expensive for you. There are health maintenance organizations, or HMOs, and those are, all right, HMOs are it's a contract with a specific doctor or a specific health provider, maybe a hospital, and it says all of our people, all the people in our organization or health insurance are going to go to you, and then you are going to provide their care. Whereas PPO is a little bit more like, it's a little bit like wider range, like you have more options. You can go to a lot of different hospitals, a lot of different providers, whereas HMO is a little bit more selective, and that's probably why the number of people who are receiving HMOs have been decreasing. I think people appreciate the choice, and employers maybe have people who live in various different cities, and so it just becomes more difficult, I think, to provide HMO services to a vast number of people. Closed panels HMOs, where the people that you make a contract with, they only treat people from that HMO, whereas open panel HMO, everybody, or they can treat people who are part of the HMO and then people who are not part of the HMO. And then there's an independent practice association, which is like a third party that is created in between the HMO and the provider. It's just so easy to understand and simple, right? All right. Other arrangements for delivering health care, right? So what a lot of people have wanted is a national health insurance. And this is what most other rich countries do for their populations, and what a lot of people feel like we should do here, but I'm sure there's people who disagree with that, of course. And this is a system where the federal government basically provides health insurance for its population, right? And it is paid for with tax dollars, right? And so we are the only developed country without a national health care plan. We have tried 7 times here to create a national health care plan, but it has failed every time. All right. Some reforms that we have done in the United States. I think under President Bush, the second one, he did some work in the consumer-directed health plans. And so consumer-directed is where it gives more power to the consumer, obviously, and it says that the person themselves is the best decision maker. And because of that, we are going to set things up so that they are rewarded for taking care of their own health insurance, their own health care needs, by doing things like giving them a health savings account. And so this is like a savings account, basically. We actually have one here in my family, and it's a credit card, and you get to use it to buy health care. Right? And the advantage of it is that it's not taxed. And so money goes from my paycheck directly into the savings account without being taxed, and then I get to spend it again without being taxed. So that kind of gives a tax benefit for people. But you only get it if you have really bad health insurance. So that's the trade-off for that. All right, and then the Affordable Care Act, all right, last thing here. I appreciate the fact that you've continued to watch this entire thing. It was a really long chapter, and there were a ton of slides, and I wasn't going to go this long, but I just feel like there's so many things about this that are really important. The Affordable Care Act, again, it was kind of a combination between an open market, a free market, which is what conservatives wanted, and the government stepping in, try to regulate cost and make it more equal for people that otherwise don't have health insurance. But as a result, neither group really kind of got what they wanted, and so it wasn't particularly popular in the beginning, and the marketplace is kind of complex. But as it's stuck around, I think people have gotten used to it, and I think people kind of like it more than they did at first. Our book said it was challenged by Congress like over 70 times, and they were trying to throw it out, and they almost did successfully. And then a guy from Arizona showed up like off his deathbed after like having surgery and cast a no vote, and it was really dramatic, and it's been to the Supreme Court like 3 times, and they've always upheld it. And so anyway, it still stands there on the books, and I think that overall, I think people have actually become to appreciate things like the fact that you can stay on your parents' health insurance until you're, I think, 24 or something like that. And we appreciate the fact that health insurance companies can't say no to us even if we have a pre-existing condition. So anyway, that's all I'm going to share for this chapter.